In terms of cuts and grazes, one of the areas that I didn't address was the use of razors and other devices that particularly women will use to remove unwanted hair. And it's not advised to use a razor. It's not really advised to use wax. Now, if you think through, hopefully you'll be able to work out the rationale behind that now. A razor will open up very, very tiny cuts in the skin. Can't help but micro cuts in the skin. They won't bleed, on the whole, it shouldn't do. You won't even see them. But if you were to put on an alcohol-based deodorant, you'd feel them because it would sting, indicating that you've actually tiny cuts in the skin. So for that reason, you've opened yourself up to infection. Wax works the other way. Anything that causes the skin, the hair to be ripped out will cause a little bit of inflammation. So you've got bit extra blood to the area, bit extra swelling. So those are the rationales for why you shouldn't use those things. If you choose to, you're taking a calculated risk for that in an area that you know is quite delicate because that's why you had your surgery. Putting a blood pressure cuff on which constricts and constrains so that the whole design is to cut the blood flow off temporarily so that we can take your blood pressure may be enough that it tips the balance for some people and they develop swelling. They may not, but if you're having repeated use of it, it may be a risk that you don't want to take, particularly if you have another arm that isn't affected. For people who've had both sides, the choice can be the leg. The leg is a little bit more uncomfortable for most of them, but it's a choice you may choose to take.
Well, there's been concern for some time that either having blood taken from an at-risk arm or having chemotherapy given to that arm increases the risk of lymphedema. And there are certainly numerous anecdotal stories of patients developing lymphedema within 24 hours of having a needle injection in the affected site. But it's only just recently that evidence has been developed to show that there is a real risk of venipuncture, for example, triggering lymphedema. So taking blood from an at-risk arm does increase the risk of lymphedema. Now, the advice, therefore, is to always use the other arm. That's not always possible, just like it's not always possible to give chemotherapy through the other arm. And therefore, the medics involved have to make a rational decision on what's going to be best for that patient. I think the first thing to do is to make sure that the medics are aware that a needle prick will increase the lymphedema, and doing everything to use an alternative site to the affected or at-risk arm is recommended. Well, if you are at risk of lymphedema and yet you're aware of that swelling could affect you, and you're going on a long-haul flight, there is no evidence that putting on an elastic sleeve helps in that situation. That may be one step in terms of prevention, one step too far. But I think there are other factors one should consider, such as positioning of the limb. If you have an arm and you hang it down, it's more likely to swell than if you rest it comfortably, perhaps on a pillow held on the lap for periods of when you're resting or asleep. Similarly, it's always worthwhile doing simple exercises to just make fists and relax and bend the elbow backwards and forwards, lift the arm, and general full movement of the arm from time to time as regularly as possible, as indeed the airlines will advise in terms of lower limb exercise and prevention against DVT. So the principles of just regular movement without going to extremes on an aeroplane are to be advised.
I think for healthcare professionals, when they're presented with somebody who's questioning whether they have lymphedema, question number one is, as a healthcare professional, are you qualified to make that judgment? If you're not, then it's best to refer straight on to somebody. Give appropriate reassurance. If you have access to the leaflets or to the internet, be able to give them information about the British Lymphology Society or the Lymphedema Support Network, the patient group, that's perfectly valid. But if you are not experienced in lymphedema and it's not your area of interest, then it's best not to dabble, refer on. However, if you do have an interest in lymphedema, my experience as an expert is that one of the most important things is to assess the patient properly. And that includes looking at them undressed, because just to look at the area that they present doesn't give you a whole idea of the picture. We have had experience in the past where people have only looked at the area that's been presented and missed other medical clues that actually required further treatment. Because swelling is not always due to lymphedema. There are other medical conditions that are quite important, requiring medical treatment, that would be missed if not properly assessed. However, once assessed, if confident that there is no other medical reason for the swelling and therefore it's lymphedema, then it's important to identify appropriate treatment plan. Again, that may or may not be something as a healthcare professional they're either qualified or equipped, because there are people who may have the experience and the knowledge but not the time and the equipment to provide that treatment. Then again, it's referring them on to appropriate service, and the British Lymphology Society is a very good place to make contact with if you're not sure who's available in your area. My personal experience is a lot of people who present very early with hardly any swelling to be seen can be dismissed by healthcare professionals as not having enough swelling to warrant treatment. Actually, at that point, the appropriate treatment is, in my view, exercise, skincare, prevention of infection, and if the exercises are done regularly and appropriately, some of those patients may never ever develop proper swelling that can be identified by a healthcare professional. If you develop lymphedema, the treatment that you should expect, what you should expect from a healthcare professional who specialises in lymphedema or who is providing a lymphedema service, is that they should assess you fully and identify the amount of swelling, the extent of the swelling, and that there is no other medical reason for swelling that needs to be treated by a doctor. Once the assessment's done and it's agreed lymphedema, we know how much swelling and what's appropriate, provide a treatment plan that's agreed with you. So you know what's your part of the deal, what are the areas that you need to do, and what are the areas that the healthcare professional will do. Lymphedema is largely a self-treated condition with elements added in from the healthcare professional. So for mild lymphedema, depending on where the swelling is, if it involves the limb, then usually a sleeve or a glove, if the hand's involved as well, will be fitted that provides a containment to the swelling so that the muscle activity can exercise and pump against that, but also it just provides a practical limit to how much swelling can occur during the day. Then overnight it's not needed to wear because everything plays catch up and the limb is not dependent, you're not working the limb, so you're not producing more fluid during the night. So wearing a garment, adding in the exercise program, similar to what you've already done whilst at risk of lymphedema. Skincare is exactly the same. They may or may not add in some form of massage. The actual exercise program that I teach is massage by exercise. It follows exactly the same route as a self-administered massage route would be. For those who have more severe swelling, then there may be more intensive treatments that are added in. But largely the aim is to limit how much swelling, further swelling can occur, and with exercise and wearing of garments to encourage the removal of what swelling that you do have, whilst then maintaining the reduction long term. It may or may not be necessary once swelling has developed to have any visible treatment long term. There may come a point, hopefully there will, where with the wearing of sleeve, the exercise skincare, the swelling is sufficiently reduced that it's exercise and skincare alone.
The treatment of lymphedema is physically based, and that applies to lymphedema at the very earliest stage, and it applies to lymphedema at later stages. The early stages of lymphedema are treated somewhat more simply in the sense that exercise and movement is encouraged, because it's that stimulates the lymph drainage in circumstances where obviously the lymph is having difficulty getting out of the arm, otherwise swelling would not occur. And it's encouraging the patient to use the arm normally, but not to excess, to make sure that specific exercises are undertaken. Swimming, for example, or water exercise is the one exercise I'm very keen on, because you have gentle but not big resistance created by the water to overcome, and you've got the pressure of the water, which is acting a little bit of adding some compression to the arm. But exercise and movement, number one. Two, a level of compression applied to the arm in the case of arm lymphedema is helpful, not because that compression, be it in the form of an elastic garment or sleeve, or in the form of bandages, not because that compression is trying to squeeze fluid out of the arm like toothpaste out of a tube, but actually the point of the compression is to act as a counterforce to the pumping of the muscles within this compressive tube, as it were, created by the sleeve or bandage. And so the pumping effect on the lymphatics is that much greater. We also introduce massage. This is mainly aimed at improving lymph drainage from around the shoulder and the truncal areas in the case of a breast cancer patient, because the muscle pumping is tending to move the lymph up towards the trunk in the hope that it's going to get away. But of course no particular treatment is given as far as exercise or compression is concerned up on the trunk. So that's where we use massage in those situations. And the principles are still the same in more severe forms of lymphedema, except we will introduce more intensive compression using bandages rather than the sleeve, and more intensive exercise and more intensive massage in the hope that we can therefore reduce swelling and then move on to a maintenance phase involving elastic sleeve, normal use of the arm, gentle exercises, and perhaps massage now and again. Well, I've been interested and researching into breast cancer related lymphedema for some 15 years, and over that time I think we have shown that the development of lymphedema is simply not due to obstruction under the arm, which is what medics have always considered to be the simple explanation. It's not a simple obstruction, it's far more complicated than that. And that probably illustrates why we then have more difficulty in fully understanding who's affected, why they're affected. It's much more complicated. When I first became involved seeing patients with this condition, what struck me was the lack of understanding there was in terms of what really caused it, why it developed. But also I was struck by the attitude of the medical profession at that stage, who largely said, well, it won't kill you, and there's nothing much we can do about it anyway. And while it is not fatal in the same way that the cancer can be, the level of morbidity, in other words suffering, that can develop from lymphedema if left to progress is quite considerable. And I felt that the attitude of the medical profession was born out of ignorance and no real knowledge of how best to tackle this problem. It's true to say that we still don't have any cure for lymphedema, and treatment, although effective, needs to be lifelong effectively. But apart from myself, I'm not aware of too many research groups who have been looking into the mechanisms for the development of breast cancer related lymphedema. The reasons for this, I think, are numerous, but one of them has been the fact that the lymph system has been considered unimportant, but also because there are not good enough techniques for investigating the lymph system. And I think that's what's held the scientific community back. That is changing somewhat now, in that molecular biology is allowing greater access to understanding the genes and proteins that make lymph vessels form and work. And I'm optimistic that that might make the area more fashionable. It might then attract better funding, and we may then be able to make more advances. But it does need to get more scientists and academic clinicians involved, and that's not, in my view, really happened yet. I believe that there may be patients who are more genetically predisposed to lymphedema than others. And at the moment we have no means of testing that. But hopefully in the future we might be able to identify, even before breast cancer treatment is undertaken, who might be more at risk of lymphedema and who might not be at risk at all. And it would be very nice to feel, if the risk was negligible, that we wouldn't have to worry them or burden them with excessive information on lymphedema when they're already burdened with a lot of information about the cancer and its treatment.